Hello all, welcome to Medicine 2020. Today we will discuss in 20 minutes. We will maximum try to discuss the main pathophysiology and basic treatment of pulmonary thromboembolism here. So the thrombus is embolized. Embolus in Greek means stopper. Okay, stopper. So when a thrombus embolizes the vessel, that means it impedes the circulation, then it is called the thromboembolism. Mainly in lungs it happens due to two main reasons. One is DVT and other is hypercoagulable states. They include protein C, protein S deficiency, hyperhomocystinemia, etc. And now there is a virtuous triad of thrombus formation that is characterized by stasis, hypercoagulability, and endothelial injury. Okay, this is the Worker's triad of thrombus formation, thrombosis. There is an increased risk if these three are there. So when there is a pulmonary thromboembolism is a pulmonary disorder characterized by localized decrease of perfusion, hence thereby decreasing the oxygen exchange from alveolus. So what happens here? When there is a blood vessel supplying the alveolus, here it carries from here. It supplies from afferent and efferent and carries from efferent. This O2 which is present here is exchanged. When there is an embolus formation, this alveolar space and air goes wasted. This results in increased dead space, both anatomical and physiological. If the thrombus is minor, the effects will be less. Usually this is thrombolized by the body, okay, by antithrombin mechanisms. And if it is major, this is where the major chunk of the lung is affected, okay. Then this causes symptoms and signs, okay. Now we will discuss in brief. There are few types of embolus, okay. We'll discuss right here. There are few types of embolus which cause infarction or without infarction. Infarction is the death of tissue, right? So embolus without infarction, so the tissue function can be restored, whereas with infarction, that means tissue is dead. And then this without infarction, the circulation is maintained by bronchial artery. And in third case, it is massive occlusion, like saddle embolus. At the bifurcation of the pulmonary artery, there can be a major embolus. This is called saddle embolus. It obstructs major arteries. So massive infarction will occur because of the gross impairment. And multiple emboli, that means a shower of micro emboli causing multiple infarcts. These multiple infarcts can impair the lung function grossly, or if there is no infarction, there can be a temporary derangement of the lung function. Here there is a brief pathophysiology. When this embolus is launched into the circulation, that means it is impeding. What happens here is this vessel, which is before, the proximal segment, it will undergo vasoconstriction because this area is not able to exchange the gases. So in order to transfer this blood from the blocked area to the free area, there will be a reflex vasoconstriction. So this is a protective mechanism to increase oxygenation. Okay, this oxygenation, this will cause the lung function to temporarily be better if the area is well ventilated. Okay, and then here after this infarction, after this ischemia, what happens? There are inflammatory markers. Inflammation occurs and this causes multiple things, like it triggers thrombosis here also, and again edema and atelectasis. These three will occur in response to the inflammatory markers released in the tissue. So when these occur, when there is an edema, usually what happens, if it is massive, there will be decreased O2 exchange. This causes multiple symptoms like tachypnea or dyspnea and increased work of breathing and chest pain, okay, and decreased oxygenation. That is measured by pulse oximetry or ABG. Okay, this can progress into shock or MI. Okay, we will see how. Here we'll just discuss how it happens. What happens here is, when there is an embolus in the pulmonary artery, this will have a back pressure on the right ventricle. Okay, there will be right ventricle dilatation. This causes right coronary artery constriction, which lead to MI, which is seen on blood investigations by increasing troponin or CKMB. Troponin is the better marker. This is one of the causes of MI, and this dilatation of the right ventricle will impede the function of left ventricle also. Okay, this impede the left ventricle function. This leads to shock and gross hypoxia, and this in turn can also precipitate MI. So it is a very vicious cycle. This is what happens when there is an embolus obstructing the major arteries. So from here we will go to what are the changes that we observe. One is the hemodynamical changes. Increased pulmonary vascular resistance, as I told, to shunt the vessels. This is due to vascular obstruction and vasoconstriction, and there is decreased gas exchange and increased alveolar dead space, because this is due to shunt formation and tissue death and vasoconstriction. Here, increased perfusion of lungs with low ventilation perfusion ratio. See, the most common sense is the predilection of thrombus will be more towards more perfused areas, right? If there is less perfusion, how can the thrombus go there? Their vessels have to be more in order for the thrombus to dislodge to that place. So less perfused areas are more ventilated, so there will be VQ mismatch, and decreased cardiac output, decreased PO2, and right to left shunting will be there. Okay, and this increased work of breathing, as we have seen, decreased due to decreased lung compliance because the tissue is dead, and increased airway resistance, the atelectasis, and loss of surfactant causing alveolar edema and hemorrhage. See, when there is edema and atelectasis and inflammation, this causes loss of surfactant, which in turn what happens here is the small alveoli which are connected to big alveoli will be collapsed fast and quick because the closing pressure is very low and the pressure inside the alveolus is very high in small alveoli. Okay, here there will be reflex bronchoconstriction of due to inflammatory markers, and ventilatory control, increased respiratory rate as in tachypnea. So this is how the pathophysiological changes will affect. Okay, there are few conditions where there is increased risk, as we have discussed. So immobilization, it has shown in few Japanese studies that more than or equal to 2 hours of TV time will increase thromboembolism or DVT per se by around 15 to 25% per day. Okay, this time is per day, 2 hours, more than or equal to 2 hours TV per day. So here few other factors like nephrotic syndrome, where there is loss of anticoagulation proteins, and few other conditions like vasculitis. Okay, and pregnancy is a hypercoagulable state, surgery, trauma, mainly fractures of lower limb, pelvis, hip and tibia are more associated with the DVT, which dislodges and to form thromboembolism. So in order for not to form the thrombus, there are few steps which have to be taken. There are preventive steps. These preventive steps are anticoagulation with low molecular weight heparin or warfarin. Here, if it is in case of warfarin, it will take 5 days for its effect to occur from the day of starting. So along with it, you have to give enoxaparin initially. Okay, so that the effect is better from the start. And after 5 days, you can discontinue enoxa and then continue warfarin. Enoxaparin can be discontinued and warfarin alone can be continued. And other oral drugs like aspirin, clopidogrel, these help only a few. This can only help so less. The effect is less, but there are few 10A inhibitors like epixaban and other antithrombin drugs, dagabatrin, antithrombin drugs, anti-thrombus formation drugs. Okay, dagabatrin and epixaban. These are oral drugs and inhibit factor 10A, which is the common pathway, and therefore it prevents the thrombus. As soon as the thrombus occurs, how do we diagnose it? diagnose it. Okay, we'll see here how we diagnose it. As soon as the thrombus forms, there are few tests which can be and should be done immediately when there is a score called Wells score. Okay, there is a score called Wells score. This Wells score says the risk of PTE or DVT. This Wells score gives risk of PTE or DVT. For PTE, we have few points like signs and symptoms of DVT, alternative diagnosis should be considered, and heart rate of more than 100 per minute, that is tachycardia, and immobilization for more than 72 hours, or surgery within past 4 weeks, and prior history of pulmonary embolism, hemoptysis. Why? Infarct, inflammation, bloody discharges, hemoptysis, cancer. There are few cancers which cause procoagulable states. Okay, these will have scores individually. This can be remembered by 2, 3, 1. Okay, that means two threes. Sorry, yeah. Score is 3, 3, 3, and 1.5, 1.5, 1.5, 1, and 1. These are this is the scoring system. For the so high likelihood, if score is more than 3, high likelihood of PE. Moderate if it is 1 to 2. Less than 1 is less than 1 or 0 usually. If there is an alternative diagnosis, it can be less than 0 also, because the alternative diagnosis score is -2, but not here. Here the alternative is 3, but for DVT it is -2. Okay, this is how you see if there is any chance of pulmonary embolism. And when you take the patient for investigations, few things can be seen. First, what should be done and what should not be done. We'll see the flow chart. There is a patient with dyspnea, high suspicion of PE or DVT, existing DVT, low suspicion. Then you can, if there is low suspicion, you can go for D-dimer. It is a fibrin degradation product. Okay, and in high suspicion, you directly go for contrast CT angiogram. You can see and visualize directly where there is a block. And if you want to treat the patient, you can confirm it. If the D-dimer is normal, you see if there is a chance of DVT. Again, clinically evaluate, Doppler studies and everything. If the D-dimer is elevated, go for CT angiogram immediately. If the D-dimer is low, keep him on anticoag. If you suspect, rule out alternatives. And look for further signs and symptoms, follow up. If there is a confirmed thrombus after contrast angiogram, what will you do? So this is the gold standard contrast CT angiogram. What will you do? What you do is, Just 1 second, we'll add another page. So what you do is 1 anticoagulation, 2 thrombolysis, 3 embolectomy. These are the 3 treatments which are warranted. See, anticoagulation is majorly for mild or asymptomatic cases. That means the infarct has not yet formed or well established yet. In thrombolysis can be done if there is tachypnea or shock or when there is a compromised function. And embolectomy is an emergency surgical procedure in massive thrombus cases, and mostly thrombolysis can be done if there is a moderate or severe cases, and embolectomy can also be done in severe cases. And anticoagulation, as we discussed, the oral and injectable, that means the Clexane, that is enoxaparin 40 or 60 mg based on the body weight, and low molecular weight heparin, yeah, and apixaban. Usually what we do is we give first the injectables for 1 week or mostly 5 days you take, then shift to oral anticoagulants like apixaban. This dose apixaban will be 0.25 mg BD usually, and the INR should be maintained between 2 to 3. This INR is very important, otherwise bleeding manifestations will occur. Okay, it has to be maintained 2 to 3. If less than 2 or like less than 1, there will be increased coagulation. Okay, now if at all you take an X-ray or an ECG, because the patient is coming with dyspnea, if you take an X-ray or ECG, if you take an ECG, there is this pattern called S1 Q3 T3 pattern. Okay, there is a deep weave in Q wave in third lead and deep T wave in third lead and S wave in first lead. This is ECG. If you don't have an X-ray, if you have at least an ECG machine, you can suspect. Most likely it will be from pulmonary thromboembolism. Okay, and here if you take an X-ray, because it is not warranted to take an X-ray here, and if at all you take, you see this Westermark sign. That means when there is a vessel that is blocked, this proximal vessels will dilate. So see here, these are the dilated vessels proximally. Okay, and here if you see this, if you have a vessel that is obstructed, okay, there will be an infarct, because the bronchoalveolar segment are like mostly triangular on pyramidal. There will be a triangular infarct. This is called Hampton's hump. Okay, and you can remember it. See here also there is a Hampton hump. How to remember this Hampton's hump? If the sign is due to hampered blood flow, it will cause Hampton's hump. Okay, if the sign is due to increased water flow, that means the blood, it will called Westermark sign. So you remember it like that. It is very easy. And here see, in CT angio, you can see this one, right? This is the embolus obstructing the pulmonary vessels. So this is a saddle thrombus. So these are the few signs and symptoms, and briefly the treatment and the vascular events, pulmonary physiological events, and the pathophysiology of pulmonary thromboembolism.